Bienvenido a este simposio conjunto con la Universidad de Northwestern. Este es un simposio que comenzamos a realizar hace 2 años en conjunto con un muchacho muy talentoso que tenemos nosotros en esa universidad como cardiólogo. De hecho, acaba de terminar como cardiólogo. Es por mera casualidad el hijo de Luis Díaz y por eso supongo yo que se llama Luis Díaz también. Este muchacho está en uno de los programas más importantes de los Estados Unidos. Esta universidad está entre las 10 primeras de los programas cardiovasculares de los Estados Unidos y como ustedes saben, eh, nuevamente como lo dije ayer, la competencia programática de estos programas es enorme y este niño privilegiado lo ha logrado y hizo contactos con todos sus adjuntos para que nosotros podamos hacer este simposio conjuntos desde hace 3 años, este es el tercero que vamos a hacer. Estamos muy contentos de haberlo logrado. Esperamos que se haga una tradición, que Luis haga una larga carrera en ese hospital y en los Estados Unidos. Y bueno, tenemos una cantidad de invitados. Conmigo está el doctor Guevara y el doctor Luis Díaz Padre. Va a coordinar Lempira. Ustedes conocen todos a Lempira. Lempira es uno de los cardiólogos más talentosos, a pesar del tamaño, es de los más grandes talentos que nosotros tenemos dentro de la cardiología. Es un extraordinario clínico, ha estado a cargo de la docencia, no voy a decir los años para no hagamos cálculos de edad, pero ha estado a cargo de la docencia de la academia como casi a dedicación exclusiva por años. Eh, Tengo una gran admiración por el talento cardiológico del Empira y lo invitamos, además, se acaba de graduar de Fellow de, de la American College y hizo un acto extraordinario, se hizo un acto extraordinario donde él participó. Entonces, Lempiro, te voy a dar la palabra para que tú coordines este bonito simposio.
Muchas gracias al doctor José Miguel, que es parte del cariño lo que él expresa. Y yo voy a comenzar presentando primero, por orden de a Luis Díaz, quien es cardiólogo, es venezolano, es egresado del Instituto Ignacio Chávez de México. Me une con él una amistad desde hace muchos años y de verdad que es un privilegio compartir el podio con él. Eh, Voy a tomarme un minuto para presentar formalmente a Luis Díaz, hijo. Luis Díaz es venezolano, hizo su estudio de pregrado de medicina en la Universidad de Guadalajara, después fue a la Universidad de Chicago, donde hizo medicina interna. Posteriormente, en la Universidad de Northwestern hizo cardiología y actualmente está haciendo el fellowship en hemodinámica. Y gracias a él, como ya lo decía José Miguel, ha sido el principal artífice de que se produzca esto. Now, I would like to thank all the people in Northwestern for sharing with us this wonderful symposium. And I'm going to address Luis Diaz Intero as the main moderator of this morning. Luis, welcome back to your country. Thank you, Northwestern. Welcome to Venezuela.
Buenos días, queridos colegas en el panel y mis estimados colegas que me escuchan desde Venezuela. De verdad que para mí es un grandísimo privilegio poder compartir con ustedes esto, llevarles a ustedes un poquito de las cosas a las cuales yo estoy expuesto. Tengo la oportunidad de compartir con gente que es pionera en lo que hace y que ha sido extraordinaria e increíblemente humilde a la hora de participar sin ningún tipo de no vacilaron en lo más mínimo a la hora de decir que sí para participar acá. Voy a pasar a inglés para que ellos puedan entenderme también. Dear colleagues, thank you so much. My friends in Venezuela, thank you for all the hard work that you do. Thank you for being here. Thank you for helping me coordinate this symposium. I had the immense privilege to be here at this institution surrounded by people who are pioneers in their field and who are incredibly humble to, without hesitation, agreeing and saying yes to participate to this symposium, even though some of them, like Dr. Puthomana, is currently on vacation and he's taking a little bit of his time to share with us. Without further ado, I would like to introduce my dear colleague, Dr. Jyoti Puthomana, who has the professor title of the Feinberg School of Medicine here at Northwestern. He is the program director for the imaging fellowship, and he's currently the director of interventional and structural echocardiography. So if there's someone who is the right guy to talk to you about echo and secondary MR, he is the guy. Dr. Puthomana, thank you so much, and please, the podium is yours.
Luis, thank you very much, and thank you to the Venezuela Society Congress for extending this invite. Sorry that I'm not dressed, I'm on vacation, so it is a privilege to be with you today. Hopefully in the next Congress or so forth, hopefully we will all be in Venezuela physically there to present and to meet with all of you. Thank you for this opportunity, and as I was discussing with Louis, we thought that this would be a good title along with some cases to highlight the challenges that we face that I think as you see patients and get more experience with edge-to-edge repair, MitraClip technology, this may be an important group of patients that we will hopefully be taking care of. So as these are my disclosures. So the talk will primarily highlight secondary mitral regurgitation, the current trials that have informed us as to how to take care of these patients, and both the surgical and the non-surgical approaches that have shown what is beneficial with the current guidelines that include some of this information. And as an echocardiographer, all of you who are in this Congress who do echocardiograms and transesophageal echo, you will realize that we have a very important role in one, identifying patients, two, in identifying the right patients for the right procedure. So I will, through my cases, I'll highlight, and these days the echo platforms have become very user-friendly and the updates are really very helpful for this particular procedure. And I will show some challenges, especially as it relates to functional mitral regurgitation. And I will end with discussing some strategies, and hopefully you will have some questions about how to take care of these patients, how to identify them before some of these patients get very sick. So most of you are probably familiar with this paper from the Mayo Clinic, which was published maybe 10 years ago, showing that in our patients older than 75, clinically significant mitral regurgitation tends to be the most common lesion. We always think of aortic stenosis as a lesion of older age, but severe mitral regurgitation, and it may be that the patients who have this problem do not present as dramatically as those with aortic stenosis, in the sense that they are more complaining of shortness of breath and other symptoms. So that's why there is a concern that we are under-recognizing mitral regurgitation in our elderly patients. When we look at the lesions that cause heart failure in patients, we see from this particular image that mitral regurgitation has the highest prevalence in the older population, and the ones where the least number of patients are undergoing treatment with surgery or with other approaches. So there is a large number of our patients with severe MR that are under-recognized. So the onus is on us as echocardiographers to make sure that we are obtaining echoes to identify these patients, but also the onus of under-treatment. I will quickly touch base on primary versus secondary mitral regurgitation. My focus today is to talk about secondary mitral regurgitation, where the problem is primary, as you know, the problem is with the valve. In secondary mitral regurgitation, now has been divided. Traditionally, we thought of secondary mitral regurgitation as patients who had prior heart attacks and called ventricular functional mitral regurgitation. There is an increased recognition lately of patients who have long-standing atrial fibrillation who develop mitral regurgitation called atrial functional mitral regurgitation. I will not talk much about that today. That is an independent topic by itself. But we will talk about ventricular functional mitral regurgitation, which again has patients who have non-ischemic cardiomyopathy, patients who have cardiomyopathy due to genetic abnormalities or alcohol, or maybe in the Central South American setting, in the setting of Chagas or so forth. And then ischemic cardiomyopathy, which is the common scenario where we see patients who have had prior infarction in the inferior infralateral wall, causing tethering of the leaflet and an eccentric jet of mitral regurgitation. So I would, for all of us involved with echocardiography, I would really highlight this particular paper from about 2 years ago from the American Society of Echo, highlighting the technical aspects of obtaining an ideal transesophageal echo with the goal of helping the interventionalist and helping all of us to take care of these patients. As you are probably familiar, the American Society of Echo documents are usually very technical and give very clear descriptions of the manipulations and the images that need to be obtained to help us with patients. For example, this image such as this shows the positions of the transesophageal echo probe at different parts of the upper, mid, lower esophagus and transgastric. It shows us the maneuvers that we need to do to obtain the best image, and I will talk a little more about this right-left maneuver that we really do not use too much, but in patients with dilated left atrium, this is a maneuver that does help the probe to be coaxial with the left ventricle and thereby interrogate the mitral valve in its entirety. So I'll start off with the patient case. This case, some of you may think is a little extreme, but I just wanted to highlight that these are patients where traditionally may not have been included. But so here is a 41-year-old patient. He comes from about 300 miles away to Chicago. And he has a laminin cardiomyopathy. It is a cardiomyopathy that is due to a mutation in the desmoplakin gene. He's had low ejection fraction for many years, has a cardiac resynchronization therapy, is on the maximum tolerated dose of guideline-directed medical therapy. But over the past year, his clinical course has been complicated by discharges from his ICD appropriate, and also heart failure related symptoms. And the echocardiograms that have been done has shown that his mitral regurgitation is slowly getting worse, and which was moderate more than a year ago is now in the moderate to severe range. Given that his cardiomyopathy is likely to be progressive, he is on the transplant list both at Northwestern and at Barnes Jewish Hospital in St. Louis, since he lives close to there. So this is a patient, and what I want to highlight is the close relationship that we have as interventionalists, as echocardiographers, with our heart failure colleagues, because these are patients who are coming to us referred from our heart failure colleagues, and the onus is on the heart failure colleagues to tell us that this is a patient who they feel mitral regurgitation is the primary driver of their clinical instability, and fixing that may at least buy some time or may clinically improve the patient. So the echocardiogram that you see here, I have 4 images. On the top left, transesophageal echo, you see that the left ventricle is severely dilated, ejection fraction is extremely low. The bottom left image is a parasternal or a transgastric short axis view. Again, you see that the left ventricle is severely dilated with low ejection fraction. On the bottom right image, which I will keep coming back to, which forms the key image for evaluation of mitral regurgitation, we go to the commissural view, which is a view obtained between 45 to 65 degrees, and an X-plane or an orthogonal plane. And in this image, I have shown with color so that it highlights the location of where the jet is, and the 3D image on the top right that shows on force view. We are looking from the atrium into the ventricle, and you see that most of the mitral regurgitation is happening at the central part of the leaflet. So all of us will agree that this is a severely dilated left ventricle with severely decreased ejection fraction and severe mitral regurgitation on optimal medical therapy. So we know from the COAPT trial that most of you are familiar with, that when patients have 3+ or more mitral regurgitation, when they saw these patients over the 2 years of the course of the study, 3 out of 4 patients were going to have a complication, either heart failure admission or death. So these are patients. So our patient that I showed the image about fits in exactly into this category. So either the decision is only 40 years old, the heart failure cardiologist feels that at this time, maybe if we buy a little time till he gets a transplant, it may help us push this further, but at the same time, leaving him in severe mitral regurgitation, he is likely to have an adverse event of either death or heart failure hospitalization within the next 2 years of 75%, very high risk. This is the continuum of heart failure therapy that all of you are familiar with and doing on a regular basis. I think one of the points that may come up in discussion is about COAPT trial and what the medical therapy was then compared to what the medical therapy is currently, with use of Entresto and SGLT2 inhibitors that were not included as a trial. And this stepwise approach to management of patients shows that the role of transcatheter therapies may be somewhere, as you see patients with heart failure who have 3+ or more MR, we should be constantly thinking of, can we treat this mitral regurgitation and will that have an impact in the clinical course of the patient along with GDMT, or maybe help the patient to get more GDMT. We know from the prior studies, multiple studies looking at both mitral valve repair and replacement, that the outcomes with surgery are no different than without surgery. So surgery has been not shown to be beneficial in this patient, which is what caused the trial to be supported, called the COAPT trial, where 300 patients were randomized to MitraClip along with GDMT versus GDMT alone. And the endpoint of the investigators was primarily to show benefit of heart failure reduction. As we see here, 60% reduction of heart failure in 2 years if you got a MitraClip and were on GDMT. What was not expected but was a very important finding was this improvement in mortality, where there was a close to 40% improved survival in those patients who got the MitraClip along with GDMT. This is led to the guidelines, the valve guidelines from the ACC and the AHA being updated. So when you look on the bottom of the graph, patients who are secondary mitral regurgitation managed by a heart failure cardiologist on optimal GDMT continues to be symptomatic with moderate to severe and severe MR. The guidelines have now recommended edge-to-edge repair with the MitraClip or similar device to a class 2A indication. As an echocardiographer, I want to highlight the important role we play with our TE, where we have to provide most of this information that I have put in this slide, where our role should be to identify the etiology, making sure there is enough left atrial height, which is usually not a concern in this group of patient. We have to localize the lesion. We have to make sure the leaflets have good enough quality and length for a safe device implant. We have to make sure that there is no other issues with the with the procedure. The imaging, TE imaging, has to follow the sweep. So we need to get a 0-degree view, but always commissural view, I will show, is the workhorse of this procedure. And then 3D with on-force views, and I will highlight the role of multiplanar imaging, multiplanar reconstruction, especially when we are thinking of more than one device. And the looking at the left atrial appendage, pulmonary veins, all of which are integral, that help us to show that the procedure was successful. So I will highlight again the role of pulmonary vein interrogation. So I mentioned to you how we do not routinely use the right-left feature of our TEE probe. But what you see here on the top left image is that in a patient with a dilated heart and a dilated atrium, when the usual position does not dissect the mitral valve in its entirety. So when you do a right shift of the probe, so what you're seeing on the left image at the bottom is a foreshortened left ventricle, where we do not see the LV or the mitral valve. But by just doing a right shift on that knob, you see that now we have a nicely coaxial left ventricle and a better interrogation of the mitral valve in its entirety. So we should be using this feature, especially in patients with mitral regurgitation. I will highlight through, this is an image from the ASC guidelines, and we will go through this a little bit in detail because this image tends to be the workhorse of both pre-procedure assessment but intra-procedural guidance. So the left panel shows the significant use of commissural view with an X-plane or a biplane. And on the top left image, you're interrogating right in the center of the leaflet. So you're looking at the A2, P2 part of the leaflet. In the middle, you're moving the X-plane to the right so that you're interrogating the lateral side, A1, P1. Then you're moving to the left and interrogating A3, P3. And this becomes very important, as you see in the right panel. This kind of an interrogation helps you to localize where the most significant jet of mitral regurgitation is. Is it in the center? Is it in the lateral side? Is it in the medial side? And you see that by interrogating the jet, you want to see the flow convergence in both of the images that kind of gives you confirmation that the jet is happening exactly at the location. So what you see on the right panel, on the top right, is color X-plane showing that most of the jet is in the center. By moving the plane to the right, which is the lateral side towards the one, you see that there is some extension of the jet to the lateral side, which I will highlight in our case. By moving the plane to the left, which is the medial side, A3, P3, you see that there is no jet. So we know that in this particular patient, the jet is mostly central and lateral, and that is what we need to really interrogate to make sure the leaflets are thick, have enough leaflet length, and is safe to do the procedure. The specific challenges that are unique to secondary or functional mitral regurgitation is that, as we saw with our patient, the left ventricle is very dilated. The leaflets are usually tethered, so there is a big coaptation gap. Mitral valve area is usually not a problem in these patients. Quantification of mitral regurgitation is a challenge because, as you see in this central graph, the mitral regurgitation does not form a hemisphere that helps us to do a good PISA measurement. It usually tends to be long and linear. So many times we may underestimate the true severity of mitral regurgitation in these patients. Therefore, there is an increased recognition that use of 3D vena contracta. So what you're seeing on the top right image is measuring the vena contracta, the width of the jet at its narrowest portion at the leaflet tips in 3 dimension without a change in the baseline shift. This may truly identify the true severity of MR. So you can see here that the orifice is not circular, but the orifice is more linear. So you really want to use the benefit of 3D to interrogate this mitral regurgitation. I will not talk too much about the posterior leaflet length, but in your patients who have a prior heart attack and a tethered posterior leaflet, that tends to be usually a challenge during the procedure, where the leaflet length needs to be at least 0.9 centimeters or longer for safe device capture. So we will highlight that. So here is an example of our patient where we are obtaining a three-dimensional view and doing a reconstruction multiplanar to measure the orifice. As you see here, there are two regurgitant jets, one on the medial and lateral side, and cumulatively turns out to be severe. If we had not used 3D vena contracta measurement, the MR may have been only moderate in this patient, thereby denying the patient potential for treatment. I showed you the role of measuring mitral valve area. Again, we are used to measuring mitral valve area from a short axis view at the leaflet tips in patients who you suspect have mitral stenosis. But this use of 3D with multiplanar reconstruction, and what you may see on this image is that the blue plane, I am pulling the blue plane to the tip of the leaflet, so I'm getting the maximum orifice in diastole. And on the left, bottom left image, I'm tracing the margins of the mitral valve in diastole, and I'm getting a valve area of 11 centimeters. So any valve area of 4 centimeters or less would be unsafe for consideration of transcatheter therapy. So this one, again, in secondary MR, it's usually not a problem, but something that I will, through the next few examples, which are not the patient that we have, but I will show how X-plane imaging helps to localize the lesion. On the top left, you are going the X-plane through the central part of the leaflet. On the bottom right image, you're going on the medial side of the leaflet, so I can show exactly where the lesion is. And this example of a patient with Barlow's, I'm showing an X-plane going through the center of the leaflet. So the valve leaflet shows the length of the leaflet at the location, but also helps me to localize the area of where the most significant regurgitant jet is. So I kind of highlight again the benefit of using commissural view and an X-plane image with and without color that helps us to localize the pathology, the leaflet length, but also localize the lesion that needs to be treated. The additional role of 3D image with and without color, as you see here, the 3D en-face image looking from the left atrium into the left ventricle shows us the mitral valve and the pathology, and the bottom right image shows us that the jet of mitral regurgitation in this patient is happening on the medial side of the valve due to a flail leaflet of the P3 scallop. Measuring the leaflet length at the location of lesion is very important. As I mentioned to you, the device, for safe implant of the device, you need a leaflet length of at least 1 centimeter preferably, or at least 0.8 or more. Now the challenges that we see specifically in a patient like ours, this is a patient, as I told you, had a CRT device. So there is a lead in the right atrium, lead in the right ventricle, and a lead in the coronary sinus. So here is an attempt to do a transseptal puncture to cross into the left atrium. And you can see that the wire that is coming across the inferior vena cava to the intraatrial septum has to navigate between the three leads that are present to get optimal. So we see in many of these patients that the transseptal puncture ends up being very challenging. As echocardiographers, we have an important role to make sure that we are able to position the needle at the central part of the intraatrial septum as posterior as safely possible, so that we get the maximum height for safe navigation of the device within the left atrium. I highlight the role of multiplanar reconstruction. I think all of us, with the current platforms, irrespective of the vendor, they have some version of this available. So here in our case, you see that the use of this has really helped to localize the position of the device, to see the arms orientation, and to make sure that we are looking at both arms of the device. As you see in this next image, on the central, the 3D has shown us where the device is below the valve. By lowering the gain, you should be able to see both the arms. And on the middle panel on the left, you can see that I can see both the arms fully well, and I can see the anterior and posterior leaflet that should fall onto the device. So here is the decision was made to go in the middle of the valve at the A2P2 location, and you can see that after the first grasp of the leaflet, we see that there is a jet on both sides of the first device. The jet medial is present and the lateral. So in this case, the decision was made that we should move the device a little more to the left or a little more medial. And you see on the bottom graph that by moving the device a little more medial, we are now left with the smaller jet medial to the mitral clip, but a larger jet lateral to the mitral clip. So as we saw, mitral valve area was not going to be a limitation in this patient, and the decision upfront was that this patient was likely going to need more than one device. So here is the residual mitral regurgitation, as you see on the bottom right after the first device, which again looks to be moderate to severe. And here is the role of multiplanar reconstruction that really shows me how much mitral regurgitation is left behind after the first device. This, I think, is probably the most important role of mitral multiplanar reconstruction, is to assess how much MR is left behind and is it safe to go with the second device, number one. Number two, as you may see on the bottom left graph, that is the position of where the MR is. So when I remove color from this image, I can exactly measure the leaflet there and tell the interventionalist that I think it is either safe or unsafe to go with the second device. So I don't have an image without color, but we decided that there was safe enough leaflet length, and now the second device is coming right next to the first device with the color highlighting. So you can see in this image that the second device is oriented in a 1 o'clock, 7 o'clock position, just lateral to the first device. In the right image, you see that we appreciate that both the anterior and posterior leaflet are nicely falling on the arms of the device. And here is the commissural view with an X-plane through the second device, which is quite a distance away from the first device, showing that the leaflets are falling in nicely on the arm. And here is the final result after the second device is implanted. So we see that the MR is now maybe mild. The second device really took care of that lateral jet of mitral regurgitation, and this is this is the 3D color on the top showing minimal mitral regurgitation on either side of the device. The bottom image shows the atrial and the ventricular side of the two mitral clips that are positioned next to each other, one at the A2P2 and one between the ones and the twos, showing really good what we call tissue bridge, meaning that it is getting both the anterior and the posterior leaflet. So the challenges with this kind of a patient is I highlighted how quantification is a challenge. The decision on when is the left ventricle too dilated to benefit from this intervention. Again, we completely depend on our heart failure colleagues to be the primary team members who have to advocate on behalf of the patient. The decision on when the patient may need more than one device, I think the COAP trial showed that most patients needed more than one device. I think in fact on an average most patients had 1.7 device or so. Where should the first device be? We saw from our example that we had to move the device a little more medial once we decided that we are going to go with the second device. And as you are probably familiar with, mitral clip, which is the only device approved for secondary mitral regurgitation, comes in two widths and two lengths. So there is NTW, which is the width, XT and XTW, which is the longer device. So what device should be used at what location is again a discussion between the echocardiographer and the interventionalist with an experience of, we tend to use more of the wider clips because we want to get more leaflet in. mitral valve orifice or gradient is usually not a problem in this patient. And we saw from our example that there is this concept of jack in the box, meaning that when you put a device at the location of the jet, we see that in this patient, the jet tends to move away and there is significant residual mitral regurgitation on either side. That brings us to the last challenge, which is a patient whose ejection fraction is so low. Should we be reducing all the MR? Is it harmful when the ventricle cannot handle easier ability to empty into the left atrium? So how much MR can we safely leave behind, or should we leave behind? These are the questions that I think will come up in discussion. So this was the final gradient on the patient, 2 millimeters of mercury. And I mentioned again about interrogating the pulmonary veins in the beginning, so that this patient had a reversal of systolic flow in the pulmonary veins. And we see here that the systolic flow is now completely restored back to normal. And there is very good data to show that this restoration of systolic flow in the pulmonary veins has significant predictive ability to show clinical improvement in these patients on follow-up. Here is the 1 month echo.
I'm sorry to interrupt. Just for the sake of time, we need to wrap up.
Okay. So here is the 1 month echo in follow-up. You see that the EF is still very low, the MR is still the same. And here is the message that Jim and I got from his heart failure cardiologist, saying that this is a patient who feels much better and is doing a significant amount of extra walking. So I will end by saying that the operator experience seems to be about 25 to 30 devices to get this kind of an outcome. And identification of mitral regurgitation and quantification becomes very important, because at each degree of mitral regurgitation, there is a clinical impact on the patient. So thanks for your time, and thanks for this opportunity to speak at the Congress.
Dr. Puthamana, that was a very interesting topic. Definitely a lot of questions could have come up, but for the sake of time, I apologize. We need to move to our next presenter. If we have some time at the end, we will definitely bring up some questions, if of course you're available to answer them. Thank you very much for your time, and I appreciate it. We all appreciate it very much.
You're very welcome.
So,
thanks for the invite.
Of course. Thank you very much. I'm going to move forward with presenting the next presenter, who is Dr. Mohamed Alcazaz. Dr. Mohamed Alcazaz is one of the newer additions to Northwestern Cardiology. He comes from New York. We are very privileged to have him here, and he has taken the role of like the section chief of general cardiology, medical director, and he's also the director of pericardial disease program here at Northwestern. Dr. Alcazaz, without further ado, please, the podium is yours.
Excellent. Thank you, Louis, for that introduction. For the sake of time, I'll try to be as brief as possible. So thank you for having me here. I'll be talking about constrictive pericarditis and the development we have. So obviously, the first step is a clinical examination for them. And this is an example of a patient with Kussmaul's sign. And you can see their JVP with inspiration being kind of elevated. But we came a long way from just physical examination. And constrictive pericarditis is a very common, it's not a common condition, obviously, but it's a very important to recognize it because it's a reversible cause of heart failure. And it can give them their life back. It can reverse liver cirrhosis if they have that. So obviously, you're looking for other reasons for what looks like a right heart failure, like restrictive cardiomyopathy, tricuspid regurgitation, pulmonary hypertension, all this, these common pathologies is important. Once you think there's a constriction, diagnosing it is important, recognizing the etiology is important. The most common being either idiopathic or viral, post-cardiac surgery from a prior CABG or aortic valve surgery or something like that, and post-radiation therapy, particularly in Hodgkin patients or breast cancer patients on the left side. In other parts of the world, tuberculosis is a big one. We're seeing more and more of these other condition post-EP procedures sometimes and so on, but they tend to be transient constrictive, which we'll talk about that. The basis of the hemodynamics for constrictive pericarditis is that you have a thickened pericardium, let's say, that's isolating the heart from the extracardiac structures. So the first principle is dissociation of intracardiac and intrathoracic pressures, because the heart is encased by this hardened pericardium, and the extracardiac, let's say, caval components or pulmonic veins will see the decrease in pressure, let's say, with inspiration, as you see here. However, that gradient will not be transmitted inside the heart, and hence there's no gradient difference to allow for blood flow. So the LV will underfill in inspiration. So the second component is ventricular interdependence. As the LV filling is decreased, the RV with inspiration will increase, leading to the septal bounce and ventricular interdependence. The combination of the dissociation of intracardiac and intrathoracic pressures and the ventricular interdependence lead to all these hemodynamics we see on cath, echo, and imaging. Cath is great, but as you can see, many of the findings we like, whether high PA pressures or equalization of end diastolic pressures or the ratio of RV end diastolic to end systolic being more than 1/3, they're all not great in discriminating restriction from constriction. Obviously, respiratory discordance is very consistent with constriction, where we have simultaneous RV and LV tracing. We can also do the area under the curve for both and measure the change. But with the changes in multimodality imaging, catheterization in many cases, and there's a movement in the field to be less reliant on it and use echo and other modalities of imaging to confirm the diagnosis. Obviously, some tough cases, we might use cardiac catheterization as a supplementary tool, maybe in 20% of them. But it should not be the first line. It should not be the cornerstone. Echo is the cornerstone. MRI is supplementary as well as CT, and we'll talk about that. When we assess the pericardium, as you're suspecting it in a person with constrictive pericarditis, you're looking at the anatomy, you're looking at thickness here, you're looking at calcification. And CT is much better in that than echo. You might see some thickness, but CT is much better than that. CT is better than MRI in looking at calcifications. And even though pericardial thickness is a common thing that we see with constrictive pericarditis, as you see in this postmortem sample, anatomy is important, but hemodynamics is everything. This is a series from Mayo Clinic where they show that 26 patients had less than 2 millimeters thickness of pericardium in the pericardium, and they still had surgically confirmed constrictive pericarditis. So don't just rely solely on the pericardial thickness. Don't rely solely on pericardial calcification. You don't need to have either of them to label someone with constriction. And that's where echo comes, because hemodynamics is very, very important in it. The first thing, obviously, in most cases, you have dilated IVC, suggestive of elevated right atrial pressures, as we saw in the lady in the first slide. However, rarely we can have occult constriction where the patient is over diuresed, and you might have to do a fluid challenge to bring the constrictive hemodynamics. But the majority of the cases, dilated IVC is the first case. Secondly, many cases of patients might have ordered an echo for unexplained dyspnea, and no one is thinking of constriction. But if the tech or the echocardiographer reading it, as most of you have experienced in this, you might see a septal bounce that's not explained and has a respiratory relationship. Those patients need to be investigated and have a full constrictive pericarditis protocol, because you really can reverse their cause of heart failure. Other important findings beside the 2D ones of septal bounce and IVC being dilated, this is an important one, which is the cornerstone. The rule, which is tissue Doppler. If you have a tissue Doppler velocity in the medial side of the annulus of more than 8, and the patient has symptoms of heart failure, you should at least think of constrictive pericarditis. Because if you have a myocardial process like amyloid or otherwise, usually those E velocities, especially on the medial side, are lower than 8 in those patients. So it should be raising suspicion of constrictive pericarditis. Obviously, you need more data, but it's a great starting point. That constriction can lead the lateral velocity to be much lower than the medial velocity, which is opposite of what we know, which is called mitral annulus reversus. But for me, if you remember, the medial E velocity being above 8, higher than the lateral, is a great starting point for the diagnosis before we start talking about interventions. As we have advances in echo, we start seeing similar pattern where the lateral velocity is lower than the medial velocities, and the LV, what's called strain reversus. And the historical thing where we see respiratory variation across aortic valve, mitral valve, and so on, where you have a decrease in more than 25% in the flow across it, which is basically pulsus paradoxis. Having said that, 20% of patients with constrictive pericarditis might not have this due to very elevated filling pressure and might have to do a recombinant position or diurese them and reassess that. You don't have to have all the criteria to diagnose them, but you need to have some suspicion of it. And some specific findings, but not sensitive, is a diastolic flow reversal with expiration in the hepatic veins, as you see here. So far we have talked about constriction, the physiology beyond it, the diagnosis, how cath is good, but we don't need it in most cases. Echo is the cornerstone. Another phenomenon in echo is paradoxically what's called annulus paradoxis, which is paradoxical to the positive correlation between the E to E prime, which usually suggests high filling pressure, high wedge. With patient with myocardial disease, we have an inverse relationship with constrictive pericarditis because they have very high E prime velocity due to this constriction, leading to that paradoxis. And this is important in patients who have mixed disease because some cases are pure constriction, which do better prognostically than mixed constriction, such as patients with radiation heart disease. And we know the higher the wedge in those patients with a mix and the higher medial to E velocity, these are the red dots, these are mixed, they do worse in comparison to the pure ones with a very high E velocities suggestive of pure constriction. Similarly, we show in this diagram, and in the catheterization, the higher the RA pressure ratio to the wedge, suggestive of pericardial constraint being the main problem, the better that these patients do after pericardectomy, because it's not a mixed myocardial and pericardial process, such as radiation heart disease or ischemic heart disease. This is a simplified algorithm, the Mayo Clinic criteria, describing what I said, from dilated IVC to the septal motion, and the most important thing, the medial E velocity, which can help us stratify our patient into constriction, mixed, or restriction. You don't have to have all of them. The more, the better in terms of the accuracy of the diagnosis. So don't just fixate on getting the 5, 6 signs. If you have one or two, if you have 2 of them in the right clinical scenario, we have done it many times, those patients might have constriction. MRI is great from hemodynamics, but it's only one sign. They take a deep breath in, they cynate, and you see the septal motion. However, where MRI plays a role is in identifying the severity of inflammation. And that's where the concept of transient constrictive pericarditis comes. Not all constrictive pericarditis needs pericardectomy. Not all constrictive pericarditis is irreversible. Many of them are realizing there's a reversibility to it. And that's where MRI is better than echo. It can tell us about inflammation. While echo is much better in hemodynamic because you're looking into more than just the septal bounce. You're looking at all these tissue Doppler and so on. But MRI adds a layer of detecting inflammation, which can suggest reversibility. It can help us with different protocols, identify the thickness, identify edema on T2 stir imaging, or LGE on the pericardium, which suggests neovascularization and suggests inflammation. Very different than myocardial LGE, which suggests scarring. Pericardial LGE suggests vascularity, and usually there's not much vessels in the pericardium unless you're inflamed. Versus in the bottom figures, it's burned out. There's no edema, no inflammation. If they have constriction in the lower patient, they probably need pericardectomy. In the upper patient, we might use anti-inflammatories first before we go to surgery. And that's where the concept of inflammasome, where our patients, we're recognizing more and more there's an inflammatory component in some of those cases where a stressor, whether it be a pathogen, whether it be an injury, whatever it is, indicates this vicious cycle of driven by IL-1 alpha, as well as beta eventually. And we can target this at different pathways points, whether NSAIDs in the COX cyclooxygenase inhibitor component, steroids, or even IL-1 inhibitors, which is an advancement. We have such as rilonacept and anakinra and others, which can break the cycle. And Rhapsody trials showed in patients with recurrent pericarditis, not necessarily constriction, that these drugs are very effective with inflammation. And there's a whole shift in the paradigm of treatment of pericarditis that, sure, we can use steroids, but maybe those biologics, injectables, we should bring them sooner. We're still trying to study them and understand them better, but maybe if we have a lot of LGE, high CRP, maybe we prefer IL-1 inhibitors over steroids. And obviously some that comes into the cost effectiveness, it comes into the availability, but this is an advancement in the treatment in the medical therapy component of pericarditis. And that's where the spectrum of disease comes from using MRI in addition to echohemodynamics, even though you have constriction, but you're trying to label them. Are we in the acute phase? Are we in the subacute reversible constrictive phase? Or we're burned out and calcified and we need surgery? And the treatment ranges from triple therapy, NSAIDs, colchicine, prednisone, and biologics, all the way, obviously adding diuresis if needed, all the way to surgery. And we know effusive constrictive pathologies where we drain the pericardium and there's still elevated filling pressures after we do that, it could be transient. And rarely those patients need pericardectomy because either resolve spontaneously or they get anti-inflammatories. And this is from the Mayo series where they followed 33 patients. Only 2 of them ended up with pericardectomy. So identifying transient constriction, identifying effusive constrictive physiologies are very important because we have therapies that are very effective. And this is a case of a patient of mine who came in with symptomatic large pericardial effusion that was drained by our interventionalist, and they still continue to be symptomatic. And if you look at their echo post-drainage, you see this exudative fibrinous stranding with a septal bounce, suggestive of effusive constrictive physiology. And after anti-inflammatory therapy, this guy actually required triple therapy, and now he's only on rilonacept. We see the resolution of the effusion and the septal bounce. And if you look at their MRI, the whole thing lit up. And that guided our therapy. He's 1 year out on rilonacept, which is an IL-1 blocker. And these are marathons. You don't just treat them for a month or 2. The average treatment is a few years for those patients who potentially is. But we know the response very quickly. Within a few weeks, we know which direction we're going. Is this becoming reversible, or the patients are really going to need eventually intervention? Not everyone needs an MRI. If they're having full eggshell calcified pericardium, chances are it's irreversible if they have constriction clinically. And that's where we're publishing in JACC best practices for pericardectomy and pericardial disease. So once we diagnose constriction, we're trying to label them. Are they transient, effusive constrictive? Is there inflammation on MRI? Can we use anti-inflammatories, whether NSAIDs, colchicine, steroids? Or we're heading toward pericardectomy if they're refractory, or they're from the get-go chronic, a lot of calcification, on diuretics, obviously understanding the risk of surgery, and we're going straight to pericardectomy. I mentioned here the centers of excellence because, as with the mentioned by Dr. Buthamana, we need high volume operators. TB pericarditis is a subset where we obviously going to recognize it and give them anti-TB therapy. Steroids selectively in cases who have large effusion, constrictive physiology, high CRPs maybe, or inflammation. We avoid it in HIV patients due to the risk of Kaposi sarcoma. And if they're refractory after maybe 4 to 8 weeks of treatment, we might consider pericardectomy in those patients. Pericardectomy, which is the last advancement in cardiac surgery, whether intraoperatively or perioperatively, our approach is radical pericardectomy, which means phrenic nerve to phrenic nerve and even diaphragmatic pericardium all the way to the superior vena cavas. Radical resection usually requires pulmonary bypass. It requires manipulation of the phrenic nerves. We think it has better long-term benefit. There's some more data for that. Some patients who will leave some pericardium might have recurrence of constriction. Partial might not need heparinization or bypass, lower risk of injury, but there could be a recurrence. And we have some data suggesting maybe complete is better. Being off pump or on pump, maybe not much different. And this is a sample of a patient who ended up requiring pericardectomy, and you can see how thickened and probably irreversible and calcified this is. The most important when we talk about pericardectomy is to have the right indication, not to do it too early, not to do it too late, and to risk stratify them. Doing pericardectomy in a radiation chest where they have lung disease, porcelain aorta, is very different than doing it in a younger idiopathic one with or without liver disease. Understanding the liver status, understanding the kidney status, the cardiac output, the RV function plays all a role because some of them might go acutely postoperatively into acute MR, acute TR from the dilatation and the distension that happens after you relieve the constriction. We need to be prepared for RV support, as whether mechanically all the way to ECMO for them, and be careful surgically not to injure the myocardium because sometimes it can be calcified, and so on. In summary, there is advances in diagnostic imaging that goes add to the physical exam for those patients across the world of echo, which is the best for hemodynamics, CT, and CMR, the best for inflammation, and cath selectively. Obviously, a lot of patients can get CT and cath perioperatively to look at the coronaries and so on, but it's not a must in every case from a hemodynamic standpoint. Advances in medical therapy, IL-1 inhibitor as an option, and we're still learning. Should we go to surgery first or wait longer? And advances in surgical care, whether the choices of pericardectomy is the centers that do them, and the movement towards centers for excellence in pericardial disease. Thank you all for listening, and thanks for the invite.
Dr. Alcazar, thank you very much. Thank you very much for this thorough and very high yield approach to constrictive pericarditis, which I think is something that we definitely, underdiagnose. I want to address the podium and see if we have time for questions. Mis queridos colegas en el podio, como hay tiempo para preguntas, deberíamos hacer un breve resumen antes de seguir adelante.
Gracias, Luis. Thank you, Dr. Altesam. A very thorough review of this topic. I'm going to make a brief summary of the main points for the people here in Spanish. Bueno, el doctor hizo, por supuesto, no les voy a dar media hora de conferencia otra vez, se asusten, sino una de las cosas que yo me parece que fueron muy importantes y es que voy a resaltar los puntos importantes para nosotros en la clínica. Uno, que si nosotros que ahora estamos haciendo mucho Vexus y midiendo mucho la vena cava inferior, él hizo énfasis en no confiarse del Vexus porque en el sentido, en la dilatación de la vena cava inferior, porque muchas veces el paciente que está con una fisiopatología de pericarditis constrictiva, se le puede dar diuréticos en exceso y seguimos viendo la vena cava aumentada de tamaño y eventualmente eso confundir y demorar el diagnóstico. La otra cosa que me pareció importante que tengamos desde el punto de vista práctico es que en la medición de la onda de prima en el anillo mitral lateral mayor de 8 debe nosotros hacernos buscar más sobre patología constrictiva. La variación respiratoria, que es una de las cosas que uno más le llama la atención en el eco, solo el 20% de los pacientes pueden presentarlo, no es un signo confiable. Y cuando él presentó un caso propio donde había un derrame pericárdico que se drenó y sin embargo después de haberse drenado cuando se le hace el eco de control sigue habiendo una fisiopatología que más bien refleja una constricción. Entonces, en ese caso, él dice que es muy útil la utilización de la resonancia magnética y que no todos los pacientes necesitan hacerle resonancia magnética para hacer el diagnóstico. Mencionó lo de la tuberculosis y dice que estos pacientes que deben recibir su tratamiento obvio para la tuberculosis, eventualmente el uso de esteroides y considerar la pericardiectomía si hay una fisiopatología constrictiva durante la revisión. Creo que esos fueron personalmente son las cosas más resaltantes que él habló de las cosas de pericarditis constrictiva.
Exactamente, doctor. Eso es la verdad que ha sido muy buen resumen de lo que el doctor Alcazaz ha mencionado. Una pregunta que yo quería hacerle al doctor Alcazaz para la audiencia es, ¿necesitamos realmente utilizar inhibidores del IL-1 antes de poder considerar la pericardiectomía? Dr. Alcazaz, I have a question for you, brief question. Do we really need to go to the IL-1 inhibitor step before considering pericardiectomy in these patients?
So no, it depends on the case. For example, if it's a calcified pericardium post-TB, it's unlikely that this is going to reverse course and most likely need pericardiectomy. But if it's a younger person who having constriction and the MRI lights up completely, we can start with the ibuprofen if they're not in kidney failure or have like significant contraindication to it, or colchicine and steroids, triple therapy, like don't wait long. And then if there's no response, quickly you can add rilonacept. But it's not in every case. It's in those who are really inflamed on MRI, who we think we can reverse it. It's not in those with advanced liver disease, kidney disease, who we think is toward the end of the course of it. And in reality, there's a change in paradigm trying to get the IL-1 inhibitors earlier in the course, but we still don't have data to support that fully. We're going to have more information in the next coming years, but it is an option that we're using more in many of those patients who are inflammatory still.
Thank you very much, Dr. Alcazaz. El doctor menciona que efectivamente se basa en cada caso. No necesariamente el paciente necesita pasar por IL-1, inhibidores del IL-1 para poder ser considerado para pericardiectomía. Sobre todo casos que son muy evidentes, donde el pericardio está extremadamente calcificado y no hay mejora con el uso de NSAIDs o de esteroides, entonces hay suficiente motivación para hacer pericardiectomía. So I'm going to stop the questions there just for the sake of time, move to our next presenter. Dr. James Floody. He is one of our interventional cardiologists who specializes in septal ablation. He is the former head of the coronary intensive care unit and is now the head of the cardiovascular quality and outcomes here at Northwestern. Queridos colegas, ahora les presento al Dr. Floody. El Dr. Floody es uno de los cardiólogos intervencionistas de aquí en Northwestern. Era el director de la terapia intensiva cardiovascular y ahora es el director de calidad y de calidad desde el punto de vista cardiovascular del instituto. Dr. Floody, without further ado, please.
Thank
Go
you,
ahead.
Luis. Is my slide showing properly, the display?
Yes, you're presenting Moda.
Let me switch those. How's that?
Fantastic.
Morning, everyone. I hope everyone is recovered from last night's football match. Sorry for my attire. Louise and I had an emergency case this morning. Nothing to disclose. The medicinal use of alcohol goes back to ancient times. The middle-aged physician Villanueva said, "We call it aqua vita, and this name is remarkably suitable since it is really a water of immortality. It prolongs life, clears away ill humors, revives the heart, and maintains youth." Well, maybe not, but just want to give this some historical perspective. The use of alcohol ablation first started in hypertrophic cardiomyopathy, which is plagued by obstruction in about a third of patients. It causes symptoms primarily due to SAM, depicted here in this echo screenshot of the basal septum hitting the anterior mitral leaflet and causing obstruction. About 30 years ago, Dr. Ulrich Sigwart discovered that if you identify a septal perforator and feed it some alcohol, you can shrink that basal septum and relieve the obstruction. Now, medical therapy is the mainstay for obstruction, beta blockers, calcium channel blockers, and recently myosin inhibitors. But in the United States, they're very expensive. It's lifelong therapy, and it has some side effects, including a drop in the LVEF in about 15% of patients, so it requires intensive monitoring. So it's not a panacea for all patients. This procedure, again, has been around for a few decades. Here's some data on it. It's very effective at relieving symptoms and improving functional class, getting rid of obstruction. Here's the basics and how it's done. Usually the first septal perforator is interrogated, a balloon catheter is placed in it, and then with an echocardiographer doing the imaging at the same time, we inject some echo contrast, and that lights up the basalmost septum that is creating the SAM. Then we inject a small amount of alcohol. Usually we give 1 cc of alcohol per 1 centimeter of thickness. So if it's 2 centimeters, we'll give 2 cc's of alcohol. We'll give it over roughly at a rate of 0.1 cc's per minute. That theoretically can reduce the risk of heart block, which occurs in about 5% of patients. There's really no randomized controlled trials, but here's the best observational meta-analysis on this, and it shows really there's no difference in terms of survival for myectomy and septal myectomy and alcohol septal ablation. There's a little bit of better long-term gradient reduction with surgery. So that's for hypertrophic cardiomyopathy. I'm going to talk about some different areas where these techniques are used. And one is the concept of suicide left ventricle, which can occur after TAVR. When you relieve the valvular obstruction, you can unmask a subvalvular obstruction. It doesn't have to be in a patient that has underlying hypertrophic cardiomyopathy, and it can be really a catastrophic outcome. Here's a case that was published by a friend of mine, 90-year-old severe AS here, depicted in the diagram here, and standard TAVR was deployed, and then the patient went into shock. And it was discovered that now she had classic LVOT, spike and dome phenomenon obstruction. So they did an emergency alcohol septal ablation, the first septal perforator, and relieved the obstruction, and the patient survived. So what do you do when you have both these lesions, hypertrophic cardiomyopathy and severe AS? Well, ideally, surgical myectomy and surgical aortic valve replacement is the preferred strategy of best both. But a lot of times we get patients that are not good surgical candidates. In those cases, we typically will address the most severe lesion first if it's obvious. If not, we will do alcohol septal ablation first and then reassess. Here's a case. 6-year-old woman had already had an AVR and had a mitral valve ring, but now also had HOCM with LVOT obstruction and some bioprosthetic aortic stenosis. So what to do? Here you can see that LVOT obstruction with the basal septal hypertrophy. Here it is on CT. You can see this is not going to be good for valve and valve TAVR. She's not good for reduced surgery. So what do? We did an alcohol ablation. We got her post-PVC gradient down from 85 to 31. Here you can see the first perforator. Here it is ablated. It's missing. Her gradient went away. Her MR got better, and she felt better for about 6 to 12 months. And then her AS measured worse, so we did a valve and valve with no worry about LVOT obstruction, and she did fine. This brings to the concept of neo-LVOT. This is a very important concept when dealing with mitral valve transcatheter implantation techniques. This includes putting a sapien TAVR valve in the mitral position and also investigational mitral valve implantations. And essentially what happens is when you put a transcatheter mitral valve in, you push the anterior leaflet over into the so-called neo-LVOT, and that can cause obstruction. This can be a devastating complication, as you can see here, illustrated by these cartoons. It's more likely to occur in valve and MAC, over valve and ring, over valve and valve, but it can occur at all. The magic number is roughly, for the neo-LVT, which you got off the CT, is roughly less than 200 millimeters squared, but some say more around 170. It's the number one reason for turn down for a mitral valve and valve. There's a lot of strategies to deal with this. The most common is alcohol septal ablation. There are others. I'll talk briefly about this because this was just published, sesame procedure. Then there's another class of tricks is anterior leaflet modification. You probably heard of Lampoon, which is being displaced by Batman, which is a balloon transection of the anterior mitral leaflet. They're very difficult and time-consuming procedures, but they can be effective in the right patients. This was just published, the sesame procedure, septal scoring. Not going to go over it in detail, but it's a very time-intensive procedure. You start with the CT, then you puncture the LV myocardium with a special stato wire that's electrified from the retro-aortic position, and then with a snare catheter in the LV, you create the so-called Vine V, and then you basically pull while you're electrifying and create a septotomy in the LV. Very genius procedure, but although it's effective, kind of maybe not as good as for hypertrophic cardiomyopathy alcohol, it does increase the neo-LVOT effectively. But right now, this is still very premature. It had a high mortality, high VSD rate, high free wall rupture rate, and increased pacemaker risk. So more to come on this. We'll see if it becomes part of the strategy to deal with neo-LVOT risk or not. But for now, alcohol septal ablation, in my view, is a much safer, straightforward way to do this. Here's a case, 83-year-old woman, severe MR, had a Physio-2 ring. These rings are good because they're complete and they're semi-rigid, so they're good for valve and ring procedures. But now she has severe recurrent MR, and she's got a neo-LVOT of 167, so really in a high risk point. You can see here on the schematic illustration of a valve in there. It's going to be right up against the basal septum, so not a lot of room, kind of a risky procedure. So you can do a Lampoon, a tip-to-base Lampoon. That may help. You could do an alcohol septal ablation. You can do both. You can roll the die and see what happens. We decided to start with an alcohol ablation, and we got a tremendous increase in the area you can see on both the long axis view and in the enfase view. Plenty of room. This isn't the case, but I want to show an illustrative case of how this is done. You start with a transseptal puncture, then you balloon the septum to allow to get the valve across. place your sapien valve across the valve or the ring or MAC, whichever your pathology you're treating. And this has become a pretty quick and safe, effective procedure for those that can't undergo redo surgery for mitral valve dysfunction post-surgery. I wanted to talk about a couple other novel uses in the EP arena. The vein of Marshall, which I never knew it existed until a few years ago. It's a little branch off the coronary sinus. You can see it going superiorly here. Apparently, it supplies an area that's implicated in a lot of AFib, A-flutter, and atrial tachycardia that's very difficult to reach with catheter techniques. This was a paper from a few years ago that first looked at this in 300 patients and showed that by ablating this vein with a small amount of alcohol, like you do for the hypertrophic cardiomyopathy population, you can really reduce the burden of AFib, particularly for those that have refractory AFib or perimitral A-flutters. It's not a difficult procedure because our EP colleagues are often the coronary sinus, so getting it in is easy for them. You just have to identify and cannulate the vein of Marshall. Then it's just a balloon angioplasty technique where you put a small balloon in and then inject a few cc's in. I'll show a case, 64-year-old with AFib, had an ablation and had recurrent AFib, an atypical flutter. It was mapped out to the perimitral space. Here you can see a balloon that's hard, these are hard to read, but it's up in the vein of Marshall. There's a small balloon with contrast injected into there. That's, we know, anatomically the right spot. And we gave 3 cc's of alcohol. The purple represents, they also got a catheter ablation. The purple represents ablation. This is before the alcohol ablation. You can see that it completed the ablation and the flutter and fib were resolved. Now, I'll close by talking about something called the LV summit region. This can be an anatomical, here it is schematically, this kind of triangle that anatomically is in the LV between the left circumflex and left in the LAD, really in the anatomical area of obtuse marginals, ramuses, and diags, areas that cannot be reached with catheters or not safely reached because they're around too much vasculature, but they are responsible for PVCs or VTs. Somebody figured out that you can get catheters in there and give alcohol and ablate those areas. Here's a case of a 49-year-old woman. She had a PVC-induced cardiomyopathy. She had an ablation that seemed to improve it. Her EF improved, but then she had recurrence with PVC burden back to 18%. There's some clues that I won't go over, but the EP people can tell where this is coming from. They can map it out. And then they get in there, and this is the coronary sinus. Then they interrogate branches with electrical wires, and which they're mapping to see if that's the focus, in this case of the PVC. So my EP colleague, Nishan Verma, found that the little branch way distal in the coronary sinus was responsible for these PVCs. So we delivered 3 cc's of alcohol in 15 minutes. She had pain acutely that went away. And then her PVCs went down to less than 1% of follow-up. So really novel technique using the alcohol ablation concept to attack some EP problems. So in conclusion, medical therapy is the mainstay for LVOT obstruction, but some are refractory. For those, surgical myectomy and alcohol ablation are excellent options. Alcohol ablation is safe and effective, requires teamwork and experience. It's also part of the toolbox for transcatheter valve therapies. And it's being used now in the electrophysiology space for vein of Marshall in LV summit ablations for recurrent atrial and ventricular arrhythmias. Thank you.
Thank you, Dr. Floody. Thank you very much for that summary of the multiple uses of alcohol septal ablation that goes definitely beyond the use of the technique for treatment of hypertrophic cardiomyopathy. Mis queridos colegas del podio, por favor, siéntanse en libertad de hacer un resumen. Si hay alguna pregunta, no sé si por tiempo deberíamos
¿Aló?
movernos con la siguiente presentación.
Una pregunta desde el punto de vista práctico. Si hay un límite que se considera mínimo como para que este procedimiento sea exitoso? Is there a size limit in the ventricular septum to consider this a successful procedure?
You know, that's a great question. There's data that didn't show. Not really. That's been done on septums that are as thin as 1 centimeter. You use less alcohol, obviously. You wouldn't use, you'd probably use 1 cc instead of up to 2 cc's of alcohol. But for alcohol ablations used to prevent LVOT obstruction, VSD is a concern, but with low dose alcohol, it's very unusual to cause a VSD. But you have to be careful about the dosing of it.
Bueno, él dice que con 1 centímetro ya se puede considerar que es exitoso. No sé si pudiéramos hacer otra pregunta, Luis.
Como ustedes me digan, doctor, dependiendo del tiempo de ustedes, nosotros estamos a su
Bueno,
disposición.
continúa. Bueno, adelante entonces, Luis.
Okay. So for the
Próximo
sake of time,
conferencista.
thank you so much for answering that question, Dr. Fletty. So for the sake of time, we're going to move now to our last presentation. Dr. Tim Provias is going to be talking to us about the use of intravascular ultrasound in percutaneous coronary interventions. Dr. Provias is one of our dear colleagues. He is the head of cardiology at one of our satellite institutions, Lake Forest Hospital. El doctor Provias es el siguiente presentador. El doctor Provias va a hablarnos sobre el uso de ultrasonido intravascular para el manejo exitoso de intervenciones percutáneas de las arterias coronarias. El doctor Provias es el jefe de cardiología de uno de nuestros hospitales satélites llamado el Hospital de Lake Forest, uno de los hospitales de Northwestern. And Dr. Provias, please, the podium is yours. Thank you so much.
Thank you. Thank you. It's a privilege to present today, and thank you for the invitation. I also want to acknowledge Luis. We're fortunate to have him as a interventional fellow this year. He's been with us for the last few years, and it's a pleasure to work with him. And I think it's wonderful that he arranges this symposium. Are you able to see the screen in the full presentation mode?
We see it very well.
Yeah, okay, great. So as Luis mentioned, he asked me to present a case that was related to the use of ultrasound. So my presentation is not as novel as some of the other ones that my colleagues presented, but I think we all love coronaries, and it's hopefully a nice case. So he asked me to present about the use of intravascular ultrasound in percutaneous coronary intervention, and is expanded use of ultrasound or more routine use of ultrasound is sort of useful in these cases. So I think I have one that will sort of try to prove that point. I'll present the case, and then there's a couple of trials that I'll mention that have looked at data regarding quality or sort of outcomes in this area. So the case is a 79-year-old male. He has a history of heart failure with preserved ejection fraction, hypertrophic cardiomyopathy, but as opposed to what Dr. Flaherty just talked about, this was an apical variant type, so not causing really any outflow obstruction. He did have atrial fibrillation, which is quite common with hypertrophic cardiomyopathy, and had been ablated previously. Also some other general risk factors for coronary disease, as you'll see, diabetes, hypertension, and hyperlipidemia. He presented with some leg swelling and fatigue. He was found to be in atrial fibrillation with rapid response. You can see the EKG below, as well as acute on chronic heart failure. Some of his notable labs, he was not anemic. His creatinine was up some from his baseline. He had a mild troponin elevation, a moderate BNP elevation, an INR that was elevated. He was on warfarin, but likely from some hepatic congestion. And you can see he had evidence of hypoperfusion with an increased lactate of 3.3 and some concern for impending shock. His blood pressures were still sort of okay at this point, although soft in the 90s to 110s range. So we did get an echo, And you'll see from one of the representative views, kind of difficult images, but with the use of DEFINITY, you can see the apical hypertrophy here. The ejection fraction was measured at 35%, down from his recent, a few months ago, of 69%. There was some global hypokinesis, but more regional in the anterior wall and septum. His telemetry during his admission showed runs of non-sustained ventricular tachycardia. And so his initial course was, of course, the diuresum. Once he was a little bit sort of able to undergo a TE with cardioversion, he was cardioverted. He was started on some, or titrated on some guideline-directed medical therapy, including kind of the beta blocker and other common meds. But despite this, he continued to have NSVT even in sinus, again, which may be a phenomenon of his hypertrophic cardiomyopathy. We did get an MRI at this point that showed that the apex was thickened up to 1.7 centimeters. There was mention that there may be mid to apical inferior infarct, and you can see that along the inferior wall and along the septum. There is evidence of delayed enhancement. In talking with our cardiovascular imaging colleagues, this mid myocardial pattern is probably more consistent with hypertrophic cardiomyopathy than with actual scar. And so he did go on to have a coronary angiogram. This was his diagnostic angiogram. In the caudal views, you can see he has a fairly large circ, so at least a codominant system. I didn't show his right, which was pretty normal but small. You can see that in the ostium of the LAD, he has a lesion that was about 70 to 80%, and then also had a mid lesion here, prox to mid at the takeoff of a diagonal, again, probably 70 to 80% range. In the cranial views, you don't see the ostium as well, but you can see the lesion here in the mid LAD. So both of these lesions, neither are critically tight. In terms of our data so far, we have a gentleman who has hypertrophic cardiomyopathy, is having some NSVT, sort of difficult to know whether ischemia is driving any of what we see. Other things were optimized during the presentation. So there was discussion about whether revascularization would be indicated and beneficial. The MRI gave us some confidence that at least there was no scar in the anterior wall, so we knew that the anterior wall was all healthy and perfused, and he does have a fairly large wraparound LAD with multiple diagonals and septal vessels. So I usually will stop. I know, Luis, time-wise, we're running a little bit late, but some of the things that came to mind with me and with our colleagues was, should we revascularize him at all? If we did, would bypass be better over PCI? Again, he has the hypertrophic cardiomyopathy, but being that it's apical, probably not necessary to do a myectomy or any mitral valve intervention. He didn't have any significant MR. He was evaluated by surgery and deemed high risk, partly because of frailty, his other comorbidities. And so we did ultimately decide on a PCI strategy. Some of the other things that came to mind were, would we have to use any mechanical circulatory support? His EFs were initially low, particularly when he was in AFib. They had improved some, but he did have blood pressures that remained kind of in the sort of 90s to 100s range. If we were to tackle this, would we have to stent back into the left main, or would we be able to just kind of cover the ostium of the LAD? If we came back into the main, would it be a provisional versus bifurcation strategy? And then obviously, should we use IVUS, and would we need to do any calcium modification? And I think, calcium wise, it was difficult angiographically to determine whether there was a lot of calcium in this vessel. So I know my practice and a lot of my colleagues is, definitely, certainly for proximal LADs and left main interventions to use IVUS. So we elected to stage a PCI, and we did place an intra-aortic balloon pump for the procedure for some support, knowing that we might have to stent into the left main. So you can see the balloon pump going up, and then we did do intravascular ultrasound imaging for various reasons, which I'll go over. So I always feel humbled with IVUS when I do it, because sometimes you look at a vessel angiographically and say, well, there may be a little bit of calcium. And the mid lesion in particular, you can see here, has actual 360-degree calcium, which was surprising, to me. the osteal part of the LAD had at least 180, maybe up to 270. It was hard to kind of catch the frame that showed the osteal lesion, but a pretty significant amount of calcium. And then because these lesions were one at the takeoff of diagonal and one at the ostium of the LAD, I did elect to do calcium modification with intravascular lithotripsy, the shockwave balloon. So these are just some representative images of the shockwave balloon going up. We, by having done IVUS, we're able to know the diameters and try to use as close to 1-to-1 sizing for the shockwave balloon. So this is a 4.0 shockwave balloon in the mid LAD. And then this is the same balloon pulled back. 4 is the largest. The ostium was probably larger than that, but we thought we would get some. We had the pulses left to deliver some treatment to the ostium of the LAD. So after the shockwave balloon and some post-dilation, we started to place our stents. Again, having done the IVUS, one of the challenges of this case was you can see how big the left main and the proximal LAD was compared to the mid LAD. So we knew the mid LAD was sort of around 3.5 millimeters, and there was not a stent that that was one, long enough, and two, versatile enough to use in the mid LAD at 3.5 and take it up to 5.5, which is what we knew the left main was. So we elected to use two different stents, a 3.5/22 in the mid portion of the LAD, and then a 4.5/22 stent in the proximal portion of the LAD back into the mid left main. We had obviously wired the circumflex artery with a planned provisional strategy, not seeing a lot of disease in that osteal part of the LAD. So, you know, the reason we wire these obviously is always to be prepared for this. So once we deployed the LAD stent, you can see that there was plaque shift of either thrombus or plaque. We didn't think there should be thrombus. The patient's ACTs were therapeutic during the procedure. So what we did is, after deploying the left main into LAD stent, is to rewire the circumflex. You can see the cranial view looks fine and the distal edge looks okay. So we were able to rewire the circumflex. Before we did that, on the left panel here, you'll see proximal optimization of the left main. So opposing the stent well enough to be able to rewire the circ and not be underneath a stent strut. So we used a 5.5 balloon, again, knowing what our diameter of our left main was, and then rewiring into the circumflex and using a series of balloons from 2 up to 3 to open up the side strut of the circumflex artery. After doing that, we were able to pass the IVUS into the circumflex through the stent struts. And on the right panel, you'll see that there was indeed a shift of plaque into the ostium of the circ that we knew we would have to treat. So probably not one of the scenarios where you could just balloon into the circ, but would have to place another stent. Normally, when you know, I tend to do left main bifurcations, I tend to use a DK crush technique that, based on data, has slightly better outcomes in terms of patency and target vessel revasc. But obviously, in this case, having used a provisional strategy, we thought about either a TN protrusion strategy versus a culotte. Because of the large sizes of the vessels, I thought that TN protrusion would leave a lot of, you know, free-flowing material in the left main and potentially make it difficult to get back in. So we did choose a culotte strategy. We passed another stent into the circumflex through the side struts and deployed that. This strategy, as you know, requires a lot of rewiring. So you have to pull your LAD wire so it's not trapped between the stents. And then you have to rewire, and we were able to do a final KISS balloon. Again, sort of given the very large size of the left main and the large size of the branch vessels, we had to be careful in terms of our sizing of the KISS balloon so that we wouldn't overdilate the left main. We chose two 4.0 millimeter balloons, even though the osteal vessels were closer to 4.5, because that would give us a sort of more optimal diameter in the left main. So after kind of that final kiss ballooning, you can see we had a nice result with a nice new carina in the left main going into both the LAD and the circumflex. So the caudal and cranial views there, showing that the vessels are patent, normal flow, no distal injuries. We had, incidentally, which I didn't show, but we had ballooned the diagonal that we stented across in the LAD to keep that patent, but did not choose to stent that. So the takeaways from this case, and where I think IVUS has a lot of value, is upfront, about vessel sizing. I think I'm, like I said, having done this now for about 10 years, I'm still always humble to know that I tend to underestimate the size of a vessel, and I often get surprised after I've IVUSed and found out that it's bigger than I think angiographically. I think calcium burden assessment is critically important. Many times now we also have CT scans, so we can get a sense that patients are going to have calcium. But in this case, angiographically, particularly that mid lesion did not look particularly calcified, but having IVUS showed a 360-degree calcium, and we may have had a lot of underexpansion given the size of that vessel. Stent selection, I think, is important in these vessels where there's a caliber change, and particularly when you're stenting back into the left main, because you want to make sure that you'll be able to take a stent up large enough without causing any stent strut fracture. So I think in optimal stent selection, IVUS can be critically important. It helps you to optimize that proximal ostial part of the stent in your pot technique, so that you can recross in a bifurcation strategy. And then in deciding kind of the optimal bifurcation strategy allows you to make some decisions about whether you'll use a 2-stent strategy up front, provisional, etc. And then what size to use for your KISS balloons, again, particularly in these large vessels. So I wanted to just take a few minutes and mention 2 of the trials. So apart from this making the case maybe go more smoothly, is there actually data that it changes outcomes? And there are 2 studies in recent years that have looked at this. They've come out of some institutions in China. One was the Ultimate trial that looked at, there was a 1-year publication of this, but then more recently a 3-year publication that looked at randomizing patients to IVUS-guided stent implantation versus angiography-guided alone. This was in all-comer patients, and it randomized a little over 1,000 patients. The combined endpoint was met, and it was a combined endpoint of target vessel revascularization as well as stent thrombosis and cardiac death. As we often see in many of these stent trials, usually the cardiac death and stent thrombosis numbers are very low and were not statistically significant. But the primary endpoint, which is this target vessel failure, which was driven by target vessel revascularization, was significant. In the all-comer analysis, 6.6% versus 10.7%. In the study, they did a sub-analysis looking at not just the use of IVUS, but also optimal use of IVUS. And they defined that as getting to an MLA greater than 5 or greater than 90% of the reference vessel, as well as less than 50% edge residual disease or edge dissections. And when you added that added analysis of doing optimal IVUS usage, you can see that compared to the all-comers in angiography alone, you get an even bigger difference, 10.7 versus 4.2%, showing that even more, it makes it even more powerful to use IVUS. Here, just some bar graphs of the 3-year analysis, and you can see that the effect, the benefit was sustained out to 3 years. When you looked at IVUS guidance, and of course, if you looked at the optimal IVUS guidance, that effect was even more dramatic. An interesting part of the trial was the subgroup analysis, where they looked at where is this more important in what types of coronary disease and what patient populations. And a few to highlight is patients who have multi-vessel disease. You can see the analysis in terms of crossing the line of unity. The most dramatic effects were in patients who had multi-vessel disease, patients who had heart failure, patients who had bifurcation lesions. moderate to severe calcification, and then lesion length. And these are all kind of the factors that were present in the patient that I reviewed today. Another trial is a little more recent and went out further. A 5-year analysis was the IVUS XPL trial. And this one, similar to the ultimate trial, looked at IVUS guided PCI versus angiography alone. This, though, specifically looked at patients who had long lesions greater than 28 millimeters, so kind of a smaller cohort of patients. They did enroll slightly more, about almost 1,500 patients in this trial. And again, sort of a very similar phenomenon where IVUS guided PCI, their primary endpoint was very similar, with target vessel revascularization driving the main difference. And it was statistically significant. You can see they did the analysis out to 5 years, and a sustained effect at 5 years, and probably even a greater effect, which has impact on the restenosis that we know that occurs over time in stenting. So my final thoughts about the use of IVUS in PCI is that I think it helps with procedural planning and execution of the case. And I think based on some of the data, may improve outcomes in terms of target vessel revascularization, which is the most common endpoint. There is an ongoing trial now, part of the DK Crush series. It's the DK Crush 8 trial, which is looking at that specific bifurcation strategy and whether IVUS is going to prove to improve outcomes in that strategy, specifically in upfront two-stent bifurcation strategies. So that trial is ongoing and is continuing to enroll. So that was my presentation. Thank you again, and I'm happy to take any questions.
Dr. Probias, thank you so much. That was a wonderful summary of, the highlights of IVUS and how sometimes we tend to underestimate how powerful a simple tool as IVUS can be in terms of the outcomes of our procedures. My dear colleagues from the panel, is there any questions? I know that we run a little bit longer in terms of time. We apologize for that. Mis queridos colegas del podio, ¿alguna pregunta? Disculpen que nos extendimos un poco más del tiempo que teníamos esperado utilizar.
Aló, no, creo que ya no va a haber tiempo. Por favor, agradece a los profesores, pero quisiéramos antes, sí, todo espectacular. De hecho, ayer se discutió un caso muy parecido aquí, ¿cómo llamaste tú?
Fuego cruzado,
Un fuego cruzado con un caso muy similar que presentaron, el que acaba de presentar ahorita. No te retire, dijo, déjame darle la palabra al doctor Eliodoro Rodríguez, presidente de la Sociedad Venezolana de Cardiología.
Ok, dame un segundo, pues.
Ok,
Dr.
para que ellos se
Probias,
mantengan,
Dr. Probias,
deja que se mantengan
so
todavía online tus profesores, por favor.
Okay, so Dr. Probias, the podium says thank you very much, and they were mentioning that they discussed a case yesterday where there was a lot of arguing, well, not arguing, but like a healthy discussion between the use of IVUS, whether we are overutilizing the technique or is it just adding like extra expenses to a procedure that could be already expensive for a patient. So your points are well taken, and I think it adds to the point that at the end of the day we want to optimize the results, and this is a technique that has been proven to optimize the results of PCI. And please stay in line. There's some words from the president of the Venezuelan Society of Cardiology coming up.
Buenos días, Luis Alejandro. Un saludo a los profesores. On behalf of the Venezuelan Society of Cardiology, I want to thank all the staff and professors of Northwestern University for your support, for standing by with Venezuela all along these years on the Curso Cardiovascular de Caracas last year, and this year with our annual Congress of Cardiology. So we are very grateful to you, and we hope keep going with these meetings, and your support is very important for us. And I know that recently Dr. Diaz had his presentation for his degree in cardiology related with this relationship, and we are very glad for that. So we're very glad, very grateful, and thank you very much for you all. And
Mi estimado doctor,
and
muchísimas gracias.
I also want to take this moment to tell your professors, Luis Alejandro, that Dr. Diaz Quintero has requested membership of the Venezuelan Society of Cardiology. He fulfilled all the requirements of our society as an internal medicine and recently fellowship in cardiology. We are very proud of you, Luis. And for this reason, we are going to give you your membership as an associated member of our society. On behalf of our society, we are giving this diploma to your father, Luis Diaz Espinosa.
Gracias, doctor. Gracias. Thank you very much all. Incredibly humble. Increíblemente, me siento increíblemente honrado, mis queridos colegas. Gracias por su participación. Discúlpenme, de verdad que nos excedimos un poco en el tiempo. A veces nos emocionamos mucho cuando tratamos de expresar y compartir un poquito lo que hacemos día tras día. My dear colleagues, thank you so much. It's been a true honor. And I apologize that, we run a little bit past the time. We all get a little bit excited when we try to share a little bit of what we do every day. So we apologize, we thank you, and we're incredibly humbled to be here. Muchísimas gracias a todos en Venezuela. Los llevo en el corazón a todos. Gracias.